Hello my dear students, welcome. Welcome to this pharmacology session, and this pharmacology session is in the for the cardiovascular system. We already started discussing cardiovascular system, and we have already completed the chapter of hypertension, and now we are in heart failure. Previously there was a trend to call it congestive cardiac failure, CCF, or congestive heart failure, CHF. And according to modern trends, I'll just call it heart failure. Heart failure is not heart fail, which a common man, the way the common man says. When the common man, the layman says, it was a heart fail, it just means that the person was dead, and the real meaning of it is myocardial infarction. But according to your medicine, heart failure is not stoppage of heart. Heart failure is not cardiac arrest. Heart failure is not myocardial infarction. In heart failure, the heart is working, but it's failing to do its expected job. It's failing to meet the requirements, the demands of the oxygen supply. So that's the meaning of the heart failure. What will be the various strategies for managing the heart failure? Number one, at least initially, until you start the management, you'll have to restrict the physical activity of the patient. Next, restrict the sodium less than 1500 milligrams per day, and try to treat the comorbid conditions or the causes which are leading to heart failure. So go for drug therapy. The drug treatment strategies include, because your heart is failing, you have to keep the working of the heart minimal. Try to decrease the load on the heart. Try to decrease the work which the heart has to do, so that the heart will be able to utilize the energy in a better way. So the first drug treatment strategy is to use diuretics. They are going to remove the retained salt and water, and this is going to decrease the blood volume, so that the heart has to pump less amount of blood and has to exert less. Second one is vasodilators. You dilate the arteriolar side, dilate the venular side, so that the preload and the afterload on the heart is less, and the heart spends less amount of energy. Number three is ACE inhibitors, that's angiotensin converting enzyme inhibitors, or ARBs, that's the angiotensin receptor blocking agents. Both these groups of drugs are going to decrease the preload and afterload, and they're going to remove the retained salt and water, and they're going to prevent the cardiac remodeling. We'll come to this issue, what's cardiac remodeling. Next, you can think of using aldosterone antagonist. And the aldosterone antagonist is going to have opposite action to aldosterone. You remember, aldosterone produces sodium retention and water retention and potassium loss. So I'm speaking of aldosterone antagonist, so it will be sodium excretion and water excretion. So this group also will remove the salt and water, and this group also prevents the cardiac remodeling. The next strategy, the opposite strategy is, sorry, it's not opposite, but it's a different strategy. First we were saying decrease the work of the heart. Now the second strategy is stimulate the heart, stimulate the contractility of the heart. That's called positive inotropic effect. Because the heart is failing, you stimulate the contractility of the heart. Positive inotropic agents, they improve the cardiac function. So these are the various drug treatment strategies. Now we go to discuss what are the commonly used drugs for heart failure. It's not just a list of drugs, I'm saying what are the commonly used agents. In the first place, you have diuretics and ACE inhibitors and ARBs, then aldosterone receptor antagonist. Then you have the beta blockers. Beta blockers are used in selected cases. So all these drugs which are made in blue color on this slide, they are the commonly used drugs. So when you think of heart failure, at least you must know the essential information about these drugs. Diuretics, ACE inhibitors, ARBs, aldosterone antagonist, and beta blockers. Next, there is a list of drugs which could also be used in certain situations. Number one is cardiac glycosides. That's your digitalis glycosides, digoxin, digitoxin. Next, vasodilators, nitrates, and nitrates could be combined with hydrolysine. Next, you have beta agonist. They are going to improve the cardiac function. That's dopamine, and you also have dobutamine like drugs. Next, phosphodiesterase 3 inhibitors, which are going to dilate the blood vessels as well as going to produce ionotropic effect on the heart. So we call them ionodilators or bipyridines. That's milrinone. And lastly, you have natriuretic peptide. So what I advise you is do diuretics, ACE inhibitors, ARBs, and aldosterone receptor antagonist very thoroughly, and then try to study the rest of the drugs. The drugs for heart failure I am classifying from another point of view, so that you go to any particular chapter, any drug, you are sure about the action. I am trying to classify the drugs for heart failure from another perspective. Drugs without positive ionotropic effect and the drugs with positive ionotropic effect. Without positive ionotropic effect, we have diuretics, loop diuretics, bumetanide, furosemide, thiazide diuretics, and potassium sparing diuretics. Next, drugs without any ionotropic effect on the heart, ACE inhibitors, ARBs, that's AT1 receptor blockers, and aldosterone antagonist. Next important group, beta 1 blockers, bisoprolol, carvedilol, metoprolol. Next, vasodilators, nitroprusside, nitroglycerin, hydrolyzin. They don't have a positive ionotropic effect. They're going to act only on the blood vessels. Next, you have natriuretic peptide, that's BNP or neziritide. Now, the list of drugs with positive ionotropic effect on the heart, there's cardiac glycosides, phosphodiesterase 3 inhibitors, that's ionodilators, I said, they also produce positive ionotropic effect, that's milrinone, and beta agonist, dopamine and dobutamine, are going to produce positive inotropic effect on the heart. So what has happened on this slide is we have clear-cut demarcated what are the drugs which are acting on the heart and what are the drugs which are not acting on the heart. Let's go to the next slide to do the NYHA, New York Heart Association classification of heart failure. It's divided into 4 classes, and this class is telling you how much is the limitation of physical activity, the limitation of physical activity, what's the extent of the limitation, and when the patient gets symptoms. Let's follow the slide. The box number 1, the row number 1, class 1 heart failure means there is no limitation of physical activity. It means it's very mild, no limitation of physical activity, and symptoms on, when do the symptoms appear? Symptoms appear on doing greater than physical activity. So with normal physical activity, you won't have any symptoms, and there is no limitation, no restriction of the physical activity. Next we go to the class 2 of the heart failure. Is going to be little more severe than the first one. There is slight limitation of the ordinary activity, but still you can work, but the limitation is slight, and the patient gets fatigue and the symptom like palpitation on doing ordinary activity. Are you getting it? So this is little more severe than class 1. There is only slight limitation in the ordinary activity, and on doing ordinary activity the patient can get a sense of fatigue and patient can get tachycardia and palpitation. Next one is class 3. So we are going to more severe condition now. Class 3, there are no symptoms at rest. At rest the patient is fine, but even if the patient does a little activity which is less than ordinary activity, even then the patient will be fatigued. So I'll read it for you. Class 3, no symptoms at rest, fatigue on less than ordinary activity. And the last one, class 4, will be the most severe, symptoms present even at rest. Even if the patient is resting, the patient will have symptoms of heart failure. So this is NYHA, New York Heart Association classification of heart failure. Next we move on to what's systolic failure and diastolic failure and what happens in this. The left side of the table is showing systolic failure. In this there is decreased cardiac output and decreased ejection fraction, and this is usually acute and is associated with myocardial infarction. You go to the right side, diastolic failure, yes, there is also decrease in the cardiac output, but the ejection fraction may be normal. So this probably happens in situations like hypertrophy and if there is stiffening of the myocardium. We believe there is heart failure so the cardiac output must be less. But there is a phenomenon in which the cardiac output is high. This is called high output cardiac failure. And I hope you remember the conditions. These are some other associated conditions, including hyperthyroidism, thyrotoxicosis, beriberi, anemia, and AV shunts. If you want to have an idea how it could be, what's the reason of the heart failure, let's rushingly discuss the case of anemia. The patient has anemia. The hemoglobin is less. The oxygen carrying capacity of the blood is less. Now what your body can do in this situation? You cannot increase the hemoglobin all of a sudden, but you have to take care of the circulation to the various tissues. What the heart does is, the heart starts pumping at more number of times per minute, and it starts pouring the blood to the periphery because it knows that the oxygen carrying capacity of the blood is less, the hemoglobin is less. At least what I can do is, I can supply more blood. And in order to do this, the heart goes on getting fatigued. It increases the rate, it spends more energy for its action, and it's putting in more cardiac output. And if this continues, if this worsens, and you don't treat this anemia, the heart goes into failure. I hope you appreciate high output cardiac failure. So if you check this particular patient, the cardiac output will be very high, but the heart is failing. That's called high output cardiac failure. Now I initially said we'll discuss about cardiac remodeling. What is this cardiac remodeling? When the heart is failing, what happens inside the heart? Number one, when the heart comes to know that I have to pump more blood, naturally the heart starts getting enlarged because it has to develop its muscles to pump more blood, and that's called myocardial hypertrophy. So there's hypertrophy of the cardiac muscle. This is initially helpful because the heart will be able to pump more blood, but there is a limit, there's an extent to it, how much the heart can get hypertrophied. Later, the heart itself starts suffering from lack of blood supply. The heart itself is not getting sufficient energy to do this work. So there is myocardial ischemia. And once there is myocardial ischemia, there is decreased diastolic filling of the heart. And when the diastolic filling of the heart is affected, all these things together start altering the ventricular geometry. The ventricular structure starts getting altered. And this is what we are discussing about remodeling. There is dilation of the heart, and it slowly leads to the structural changes like the proliferation of the connective tissue cells. Myocardial cells have already hypertrophied. Now the connective tissue cells, they start getting proliferated. I hope you're looking at the slide, and I have shown each and every step on the slide. So have a look at the slide. Remodeling means dilation of the heart, and there are slow structural changes like connective tissue cells proliferation. And the connective tissue cell proliferation is followed by the abnormal myocardial cell proliferation. There is abnormal biochemical characteristics like fetal myocytes. And next stage is the myocytes die very rapidly. They undergo apoptosis. So there's the cell death of the myocytes. And the remaining myocytes are put to an extra stress. So remaining myocytes are subjected to even greater stress. So I hope you understood it's a vicious cycle, what we are discussing as cardiac remodeling. And what are the substances which are most likely to be responsible for this? Number one is catecholamines, which are reinforcing the heart and encouraging the heart to pump. And the second substance is aldosterone, which is producing sodium retention and water retention and putting the heart to an extra work. So cardiac remodeling is a dangerous phenomenon for this heart, and is going to worsen the condition. And if you look at this catecholamines and aldosterone leading to cardiac remodeling, obviously it will be a clue for you to understand that the drugs which will be acting against catecholamines and the drugs which will be acting against aldosterone will be the drugs useful to prevent the cardiac remodeling. I hope it was good. Now we see what is right-sided failure and what is left-sided failure. When the right side of the heart fails, that's the right ventricle fails, is not able to pump the blood, then there is increased right ventricular pressure. Have a look at the slide. RVP, increased right ventricular pressure. A stage will come when this pressure will be exerted back, because at the end of the contraction, the right ventricle is filled with the blood. Not only that, it is filled with the blood, the pressure is going back, and back it will go on the right atrium. When the pressure is in the right atrium, you go back proximally, the pressure will start increasing in the venous system, because right atrium is receiving the blood from the venular circulation. So there will be increased pressure in the superior vena cava and inferior vena cava. This is called increased venous pressure in the system, and to accommodate this pressure, the veins start dilating. So the venodilation starts, and this is what exactly you call systemic venous congestion. All the veins are filled with the blood, they are pulled with the blood, and to accommodate this blood, they try to dilate themselves to their maximum, and when it crosses the limit, the blood starts leaking out of the veins, and this is called as edema. And this is why you get edema when there is right-sided failure, and the edema will be everywhere in the peripheral tissues. Another thing is going to happen due to the systemic venous congestion. You can obviously see raised or increased jugular venous pressure. So there will be raised jugular venous pressure. The veins in the liver and spleen, they are dilated. So the size of the liver and the size of the spleen goes on increasing, what you call as hepatomegaly and splenomegaly. And the fluid which starts leaking out of the blood vessels is going to produce peripheral edema. So I hope, I'm sure you understood the classical symptoms of right-sided failure. Classical signs and symptoms is increased JVP, hepatomegaly, and the peripheral edema. Next we say what is left-sided failure. Now in this case, let's consider the left ventricle is failing. So I'm putting it first as left ventricular failure. Left ventricle is not able to pump whole of the blood which it received during the diastole, and the blood is accumulating, and when it's not able to pump the blood, its back pressure is exerted or is transmitted to the previous chamber, to the proximal chamber, and that's left atrium. So there's increased left ventricular pressure, then there's increased left atrial pressure. And this left atrium is receiving the blood from where? What's the proximal system before left atrium? Is nothing but the lungs. It's going to receive the receive the blood from the lung. So once there is increase in the left atrial pressure, the pressure is exerted back in the lungs, and that's pulmonary vein, and you get increased pulmonary venous pressure, and we start calling it pulmonary venous congestion or pulmonary congestion. And when the pulmonary vein dilates enough to accommodate this particular blood, again whatever happened in the periphery, same thing is going to happen in the lungs. And from the pulmonary vein, the fluid starts leaking out, and you call it pulmonary edema. So in left-sided failure, you get pulmonary congestion, you get pulmonary edema, and once there is pulmonary edema, the patient's respiration will be in trouble. So patient gets breathlessness, which we call dyspnea. Not only this, if the patient tries to lie down, the thoracic pressure will be increasing, and all the blood will be pulled towards that side, and when the patient lies down, he will have breathlessness. When the patient sits up a bit for some amount of time or stands up a bit for some amount of time, this pressure is going to be pulled towards periphery, then the patient will feel better. So breathlessness on lying down and feeling better on the propped up position, we call it as orthopnea. So this particular, the breathlessness associated with the posture. Next important thing happens in the left-sided failure is, if the patient lies down, if the patient sleeps at night, after some time, because the edema fluid starts accumulating, the patient gets breathless, and the patient has to sit up, or the patient has to stand up and sit up for some time. After sitting for some time, patient feels better, then the patient again goes to the bed, and after some time, again the fluid starts accumulating, and the patient gets breathlessness. This continues. So he gets the attacks, or he gets the episodes of breathlessness during the night, especially on the lying down, and on propped up position the patient feels better. This we classically call as paroxysmal nocturnal dyspnea. Dyspnea is breathlessness, nocturnal at night, and there are paroxysms because there is one event, then again you stand up, you feel better, again you lie down, again breathlessness. So that's called paroxysmal nocturnal dyspnea or PND. And no doubt when there is pulmonary edema, the patient will have cough. So I hope you are sure now you understood the symptomatology of left-sided failure, increased pulmonary congestion and pulmonary edema leading to cough, dyspnea, that's breathlessness, orthopnea, and paroxysmal nocturnal dyspnea. So this was a brief connection of the symptoms of heart failure with the pathophysiology. When the heart is failing, the body has to compensate. The body has to undergo certain compensatory mechanisms. And the compensatory mechanisms, because the cardiac contractility is diminished, because the heart is not pumping effectively, the body tries to compensate by increasing the rate. So that's called tachycardia. So once the heart failure is imminent, the patient starts having tachycardia, then there is increased peripheral vascular resistance so that the blood pressure can be maintained. Then there starts salt water retention because the kidneys are not getting enough blood supply, renal blood flow is less, glomerular filtration rate is less. That's the stimulus for secretion of renin. So renin comes into play, then angiotensin is secreted, angiotensin 2 is formed, that finally leads to aldosterone formation, and you see the effects of stimulation of RAAS, that's renin angiotensin aldosterone system. So there is increased blood volume, it leads to edema once again and pulmonary congestion. Then because the heart has to accommodate the blood and it has to pump the blood, there is increased diastolic fiber length and this cardiomegaly. All these things finally put an extra load on the heart, further diminishing the cardiac function. So all the compensatory mechanisms could lead to a vicious cycle into which this poor heart enters. The failing heart has increased sympathetic activity because it tries to produce tachycardia. There is vasoconstriction and beta 1 stimulation, that's one reason, and it leads to increased work. Then there is stimulation of renin angiotensin aldosterone system. I have written on the slide RAAS. As we saw, there is sodium water retention, increased blood volume and venous return, and peripheral venous pooling. This leads to two types of edema which we already discussed on the left side and right side. That's peripheral edema and pulmonary edema. Next, because the aldosterone secretion is more, there is direct effect of aldosterone on the cardiac muscle. And we saw, what is it? It is the fibrosis or inflammation of the cardiac muscle, and that's called cardiac remodeling. The next thing which happens is hypertrophy, because the heart has to pump, the heart is exerting more now, it has to get dilated, so there's dilation, so there's more stretching of the myocardial muscle, and the contraction goes on becoming weaker, and the heart fails to do the right work, to do the proper work during systole, so you call it systolic failure. And then there is also inability to relax and completely fill, so the heart goes into diastolic failure. So this is how I described to you all the compensatory mechanisms and how there is worsening of the heart in these situations. Now we discuss the top candidates for heart failure, and those are ACE inhibitors, angiotensin converting enzyme inhibitors. What are their effects and how do they act? See, number one, they inhibit the angiotensin converting enzyme, so the angiotensin is less, so there is vasodilation, decreased preload and afterload, and decreased blood pressure. Next, angiotensin is less, it leads to decrease in the sympathetic activity and decrease in the norepinephrine release. Number three, because it's finally going to decrease the aldosterone secretion, there is less sodium and water excretion, and there is less remodeling. Next, it will conserve the potassium. It's going to conserve the potassium. So ACE inhibitors produce these very important effects. The sodium and water retention is going to be taken care of. It will be the opposite effect. of the aldosterone effect, and the cardiac remodeling also will be minimized, and they'll conserve potassium. There are some useful or important effects of ACE inhibitors in the management of heart failure. When to use the ACE inhibitors, they can be used in all stages of heart failure, right from asymptomatic to chronic heart failure. Even if the patient has mild dyspnea on exertion, even if there are no signs of volume overload, even if the patient has no symptom, but the heart failure is getting imminent, if the ejection fraction is less than 35%, if there is ventricular dysfunction, if there is recent myocardial infarction, and all the stages of left ventricular failure with or without symptoms, these are the indications for the use of ACE inhibitors. I think we introduced heart failure in a right manner. We understood the pathophysiology, and we just introduced to you the most important group to be used for heart failure, that's ACE inhibitors. I hope you liked it. We'll continue on the further session. Thank you so much.